everyone, welcome to another Rethink Startup Community webinar. We are going to give it just another minute or so that people can join and get situated and get audio and everything like that set up. So while we are waiting, I am actually going to go ahead and launch a poll just to gauge how familiar everyone is with the ABA medical insurance billing process. So if you don't mind, just take a minute to answer the question and we will get started soon. And for those of you who are just joining, we are going to get started in just a second. If you can take a moment to answer the poll question, we would appreciate it. All right, thanks everyone who participated in the poll and answered the question, how familiar are you with the ABA medical insurance billing? Most of you said you were somewhat familiar or not familiar at all, so hopefully this webinar is going to be a great resource for you. My name is Erin Mayberry and I am Director of Community Engagement at Rethink. I am also joined by Mary Grace, who is on our Business Solutions team and is part of the startup community. I'm also joined by Michelle Helm, who is one of our billing implementation specialists here at Rethink. So she is going to be presenting on billing ABA therapy. Just a lot of information for you about the billing process with ABA and revenue cycle management. We're really excited to have her join today. Michelle, thank you so much, and really looking forward to hearing what you have to say. I am going to turn it over to you, and for anyone in the audience who has questions, there is a questions area in your GoToWebinar pane, so feel free to type them in as we go, and we will get to as many questions as we can at the end of the presentation. So Michelle, I'm going to turn it over to you now. Thank you.
Thanks, Erin. Well, welcome to the Billing ABA Therapy webinar. My name is Michelle Helm, and I work for Rethink as the Outsourced Billing and Self-Billing Implementation Manager. What that means is that I assist all of our customers on implementing with either our outsourced billing or as a self-biller. I have some slides to share, and I just want to review just some basic information and things that are important as you're thinking about starting a business, especially with working with insurance and different providers. So my first slide is talking about in and out of network with insurance companies. When providing ABA services, you're going to want to make a decision if you want to be in network or out of network. In network means that you have signed a contract with the insurance company and have received a copy of the contract with an executed date. Some of the benefits of being in network is that, one, you'll receive an allowable amount for each code that you will bill. That helps you know what you're going to get paid per code per unit. You also have the benefit of the family is going to be able to use their in-network benefits when you are billing. If you choose to stay out of network with the insurance, that means you're not going to sign a contract with them. And a couple of things to note when you're thinking about using out of network, that you won't receive an allowable fee schedule for the insurance company. So you're not going to have guidance on what to charge, what the insurance is going to pay. The other thing to note is that the families may receive the payment as you bill out of network. A lot of times the family gets the check from the insurance company and then you have to collect that from the family. So just a few items to think about when you're trying to decide, do I want to work on getting contracted or do I want to stay out of network? The next hot topic typically is rejections and denials. Rejections typically occur when you're billing electronically through a billing software. The key here is that rejections happen before claims reach the insurance company. If you have a rejection, you will see what the reason is. Lots of times it's the provider's not recognized or the policy number isn't correct. A big example of this is that Blue Cross Blue Shield has a 3-letter prefix. If you don't have that 3-letter prefix, they will reject the claim. Another big one right now is taxonomy codes missing. There are lots of insurance companies that are requesting the taxonomy code be added to each claim. If you have these rejections, it is something you can fix and bill it right back out. Important just to remember that in those rejections, again, the insurance company does not receive the claim. So if you go on the portal to look for a claim and you don't see it, you want to look in your rejections to make sure that it's not sitting there with an issue. And the second piece to that is denials. Denials are received on the EOB, explanation of benefits, from the insurance company. So once the insurance company receives the claim, they are going to either deny the claim or pay the claim, and then you will receive that explanation of benefits. Common denials are no authorization, date of service occurred after coverage termed, past timely filing, provider is not eligible to perform services. Any denial that's on the EOB will be in a number with the date of service, and then you can scroll down to the bottom of the EOB and see where the definition of that denial is. At that point, if the denial is something that you can correct, that is when you would send a corrected claim. So the difference with a rejection is that insurance never receives the claim, so you don't have to send a corrected claim. With the denial, insurance has received the claim and denied it, and so you will want to send a corrected claim. If you don't send a corrected claim, it will get denied, most likely as a duplicate. So one thing I have mentioned on here is past timely filing. Timely filing is each insurance company has a timely filing limit. When you sign a contract, or if you're going to choose out of network, you can go onto websites and find their timely filing limit. For claims to be reviewed for payment, they must be submitted before the timely filing limit. So for example, if timely filing is 90 days from date of service, then you must bill the claim before the 90th day, or that date of service is going to be denied as past timely filing. There are different timely filing limits: the first billing of a claim, a corrected claim, a secondary claim. Each one of those may be the same or they may be different. Again, that is information you would find on the contract or on the website for the insurance company. When you're billing, and if you are choosing to be an in-network provider, it's knowing who to bill under. Do you have a group contract or do you have an individual contract? So based on how you're credentialed will determine how the provider is listed on the claim. Are you enrolled and credentialed as a group? As an individual provider? The other item is, are your RBTs enrolled, credentialed with the insurance company? Some insurances, such as TRICARE and some Medicaids, enroll the BCBA, the BCABA, and the RBT. More than likely, if you enroll your BCABA and your RBT, you bill under them. So just key items as you're looking at how to bill. It is how you are enrolled with the insurance company. Another piece of dates of service and what to do with those dates of service as they age. Most billing softwares will give you different aging buckets. The first key item to know is that it can take 30 to 45 days to receive an EOB. And so we say anything in the 30-day to current bucket, those are just waiting for a response from the insurance company. When you're looking at how the aging buckets are put together, there are two options. Software can use it based on the date of service or based on the date it was billed. Very important to know, if you're looking at the date of service, if it is a date of service for July and you didn't bill it out till September, it is going to sit in a bucket and count based on that date of service, not necessarily on the date you billed it. Some things to look at when you're looking at those buckets. Obviously, the first 30 days, it's going to sit there and wait. 31 to 60, some of these are still waiting for their EOBs. If you're getting closer to that 60-day mark, recommending that at that point, look on the portal, call the insurance company, make sure they've received the claim. The 61 to 90 days, you may have received an EOB and you're sending a corrected claim. If you haven't received an EOB by that time, I would definitely go on the portal or I would call them. The 91 plus days, at that point, you should have provided a corrected claim, or what's going on, that is still sitting there. Once you hit over that 91 and plus days, it becomes difficult because you're going to start looking at a large number of claims for that patient and following what's wrong, why they're not paying. Some helpful information, as I've talked about portals, most insurance companies have a portal. They're extremely helpful. You can review claims, you can check eligibility for a client, you can submit corrected claims, you can obtain authorization. You can also submit the original claims on a lot of portals. They're extremely helpful. When we talk about the buckets and checking to see if the claim's been received, you can check way before that 30-day mark onto a portal. You will be able to watch your claims process, and you typically can see if it's been denied much sooner than waiting on that EOB. Checking benefits for clients. Recommend that this is done for every client before you see them. You want to know if ABA therapy is covered. You don't want to provide services for a patient if ABA therapy isn't covered by their insurance, unless you have another plan established with the family. You can also find out their financial information. Are they going to have a copay, a deductible, a co-insurance? That then helps the family know in advance what they're going to be responsible for. It will also let you know if an authorization is needed. Authorizations are huge for ABA therapy. I have seen recently some funders who are not requiring auth. That is a new part of ABA for me. I often tell providers, if you're told that it doesn't require auth, I would still call the auth department to confirm that. You do not want to see a patient bill out their claims and it come back that they're denied for no auth. Some random requirements and items that are very important to getting your claims paid. One of the new ones is that several insurance companies, United Behavioral Health is one of them, is requiring provider taxonomy codes to be listed on the claim. Back to the rejections, I have seen rejections come back where they're saying the taxonomy code is not on the claim. Just be aware that that is coming across for lots of funders. Medicaid can require you to include the provider's Medicaid ID number on the claim. Again, that can come back through as a rejection. MUE limits. There are limits of units per code that Medicaid and Medicare follow. What Medicaid and Medicare follow, most commercial funders follow the same limits. One of the biggest ones is the 97151, has an MUE limit of 8 units per day. Most insurance companies give you 32 units, but they don't tell you you can only do 8 units a day. What happens is I've seen providers bill more than 8 units a day, and either insurance will pay only the 8 units, deny the rest, or they won't pay it at all. You can Google MUE limits and find all of those limits per code. Just a great way to make sure that you're following the rules, and so you're not getting denials for being over the limits. Modifiers and concurrent billing, 2 hot topics. Modifiers, which can be included with many different codes for many different reasons. If insurance requires a modifier, you will see it on their allowable fee schedule. You will see what modifier is used for specific providers, or, for example, the big one that we have seen in the last few years is telehealth. What modifier is used for telehealth, what codes you can use to provide telehealth. So important that you know what modifiers. The claim can get all the way to the insurance company, and then they will deny it for missing a modifier. Concurrent billing, which means that 2 providers performing 2 services at the same time. Typically your 97151 or your 97153, 97155, or the 53 and the 56. Know if the insurance companies allow concurrent billing. If they don't allow concurrent billing and you bill concurrently, you're only going to get paid for one of those services. That information, again, will be either in your contract or you can find it on their website. There are different restrictions based on insurance companies. For example, TRICARE, they don't allow the 97153 to be concurrent with the 97155, but you can bill concurrently the 97156 and that 97153. Again, know what the insurance companies require from you, modifiers, who you need to be billing under for those concurrent claims. So that is a lot of information, and I definitely want to give time for questions. And I am more than happy to help you with any questions you have. And then I will actually turn it over to Erin regarding those questions.
Awesome. Thank you so much, Michelle. We do have a couple questions, and before I start, just a reminder, if you do have any questions after Michelle's presentation, feel free to type them into the questions pane. One of the first ones we got is more so regarding the slides themselves. So just a quick reminder, this is being recorded, and we will send out a follow-up email after the webinar, probably early next week, where we will have the recording of the webinar for you as well as the slides that were presented, so you have access to those. Michelle, one of the first questions that was asked is, which is better for insurance, enrolling as an individual or as a group?
Insurances have different rules. Some insurances, for example, Cigna, you have to have 3 providers to get a group contract. Either way, you're going to be able to bill. But again, it's based, I would base it on what the insurance company rules are about how many providers you need to have for a group contract, and then go from there.
Thank you. Next question about the portal that you mentioned. Is that Availity? I believe I might be saying that correctly, or is it a different portal?
There are several portals. Availity is one of them. TRICARE has their own portal. United Behavioral Health has their own portal. Cigna has their own portal. Any insurance company that you're going to be in network with, Google and you'll find their portal. You can sign up and get access to the portal, and it is at no cost. There are some extra features. If you want extra features, I have heard that some of the portals are charging for those extra features, but in general, you can use those portals.
Thank you. The next question that came in is, do we have to bill the insurance company when out of network, or simply charge families the private pay fee?
So that is actually an agreement you have to develop with the families. Some who are out of network choose to provide the families with the billing information for them to bill their insurance company on their own, and then they choose to bill the family. So it is really about what you and the families have agreed upon.
Excellent. There are a couple questions coming in about EMRs and Rethink and other different platforms out there. So can we spend a couple minutes just talking about what Rethink offers in terms of billing solutions?
With regards to the EMR, I think one of the hugest things that I have seen is those electronic medical records. If you need records to send to the insurance company, they are there. When it comes to your providers taking, their session notes, providing the evaluation, assessments, all of that information, it's in one location. And they take that with them, which is great. When they go into the home, they have all of their information. There's no need for paper and pencil. That is probably the biggest plus that I see every day, especially on the billing side. If you need medical records, they're right there. A couple other benefits of it are that you can see what each kiddo's information with regards to insurance, how many sessions you're billing. You track your authorizations right in that system to know, hey, I'm about out of all, or my auth is about to expire. Huge pieces, because then you can be proactive on the authorization piece. So I would say really one of the most important things is that you have everything in one spot and you can follow all that information, which in turn is better for you as a provider to be able to see the client and know, one, I have authorization, two, my session note is right here and I can bill. So I am definitely, obviously I work for Rethink, but I am a supporter of the EMRs.
And just to be clear, Rethink does offer a fully outsourced billing solution. So if you do have any more questions about that, feel free to reach out specifically to Mary Grace. So Mary Grace, if you don't mind just putting you did already. Her email is in the chat. If you do have any further questions about Rethink's billing solutions, you can reach out to Mary Grace and we will be sure to follow up with you. So Michelle, is the 8-hour unit count for one code or for two? For example, if an RBT is doing 6 hours a day, can the BCBA come supervise for 3?
So you will want to look at the NUE limits for each code. The example I gave was the 97151, which is for the assessment. Only the BCBA can perform that service. If you're looking at your 5.3 and who can perform that and how many units a day, it is a total package of these are how many units per day. It's not that this provider and this provider can only perform services. Again, important to know the rules of the funder. Another great piece about EMRs and about the scheduling piece is that specifically, I know for Rethink, if you have, for example, 2 RBTs with the same client on the same day, they will actually roll up together if it bills under the BCBA. Then you're not going to get that duplicate denial because you have 2 97153s on the same day. So also a big piece, knowing those rules of what can be rolled up and combined together so there are no duplicates.
All right, and it looks like we have one more question. Is there a general rule on how often you're billing? For example, I know some providers bill daily, but could I bill weekly for all sessions?
Yes, you can bill however often you want to. You'll find that you develop a pattern of claims going out, payments coming in. And so in that pattern, if you bill every day, that'll be the pattern of you'll bill out, you'll get paid. As it goes on, you know, if you bill out weekly, you're going to start to see that flow of here's my billing going out, here's my payments coming in.
Wonderful. Thank you so much. Again, for anyone who may have missed it, we are going to be emailing everyone a copy of the recording as well as the slides that were presented today. We also just posted in the chat a link to the startup community on Facebook. So if you're not part of our startup community yet, this is a great resource. We post all of our webinars for you to register there. We also post additional information and resources. There's great networking opportunities for any questions that you have about starting your own practice. So again, Michelle, thank you so much for joining today. Really appreciate all of the information that you shared and hope that this was beneficial for everyone who have joined. As you are exiting the webinar today, there is, I believe, a 3-question survey, so really quick and easy if you don't mind taking a minute just to answer those questions so that we can really continue to provide you as much beneficial information on starting your own practice as we can. So thanks again for everyone for attending and hope you have a great rest of your week. Bye, everyone.
Thank you.